Hello, friends and colleagues, and welcome to episode 111 of Dermasphere, the podcast by dermatologists, for dermatologists, and for the dermatologically curious. I am one of your hosts. My name is Luke Johnson. I am a pediatric dermatologist and general dermatologist with the University of Utah. And joining me, as always, wait for it, is...
This is Michelle Tarbox. I'm an associate professor of dermatology and dermatopathology at Texas Tech University Health Sciences Center in beautiful sunny Lubbock, Texas.
Our mission, of course, is to come to you every 2 weeks with discussions of some of the latest research in the world of clinical dermatology. And to help us out, we also have the Pimping Bell. Say hello, Pimping Bell. The Pimping Bell exists to highlight especially question-worthy content. For example, if you're a resident or somebody learning dermatology, or even just somebody who wants to know a little pearl, that's the time to especially pay attention. Though, of course, you always want to pay attention to us because we're so awesome. And some of our listeners may have heard that a new JAK inhibitor was just approved for alopecia areata, so I would like to talk to you guys about the trials that got it approved. So this is out of the Lancet, and the title is Efficacy and Safety of Ritlecitinib in Adults and Adolescents with Alopecia Areata, a randomized double-blind multi-center phase 2b/3 trial. Authors include Brett King and Rodney Sinclair and Robert Walk and Natasha Mesenkovska.
Woo!
How's it going, Natasha? So, Ritlecitinib recently approved by the FDA for alopecia areata in patients aged 12 plus, based on this trial, which of course was funded by the pharmaceutical company. So the short story is that this medicine seems safe, and 20 to 50% of patients have significant improvement on it. That's the short story. The following is the long story. So Ritlecitinib, a JAK inhibitor specific for JAK3. It also inhibits the TEC family of kinases, which are also involved in immune activation. Though one of the speakers at the SPD meeting says that these JAK receptors tend to dimerize with each other, so it's really hard for them to be truly specific, because even if they inhibit just JAK3, that JAK3 could be combined with JAK1 or JAK2 or TYK, and it's still rather nonspecific. This study had about 700 patients. About 2/3 of them were white and a third were Asian, with bad alopecia areata, half of them with alopecia totalis or universalis, though none of the patients with current hair loss of over 10 years duration. And they were randomized, of course, to placebo or to several different dosing regimens with ritlecitinib. It was basically 30 or 50 milligrams daily, with or without a loading dose of 200 milligrams daily for the first month. And all of this lasted for 24 weeks. Then there was an open label extension to week 48 when everybody got the drug. So their endpoint was a SALT score, SALT, which we've discussed before. It stands for Severity of Alopecia Tool. And basically, it's the percentage of hair loss that people have. So the percentage of hair on the scalp that is missing. And a SALT score of 20 or less has been shown in the past to be a meaningful improvement for patients. So that's what they were shooting for. A SALT score of 20 or less at week 24 was achieved by 30% of patients in the highest dose of ritlecitinib versus 2% in placebo. A SALT score of 10 or less was achieved by 20% of people in this group. About 50% of patients rated their disease as moderately or greatly improved, and improvements continued until week 48 when the study stopped, so perhaps they would continue after that as well. If you had alopecia totalis or universalis and you wanted a SALT score of 20 or less, good luck. Only 10% of you got there, but versus 0% with placebo, well, 10% is better than nothing, but that's consistent with known facts about alopecia areata. Totalis and universalis are just really hard to get the hair to come back. This medicine looks quite safe. Most adverse effects were mild or moderate. In the treatment group, more common adverse effects compared to placebo included URIs, nasopharyngitis. Hey, Michelle, what's the difference between nasopharyngitis and URIs?
That's an interesting question. Nasopharyngitis could be caused by anything that causes inflammation of the nasopharynx. So you can get nasopharyngitis from allergies. You can get it from irritant inhalants. People get it when there's wildfire smoke and stuff like that. So nasopharyngitis is just the name of the symptom. Upper respiratory infections is more pointing, I think, to etiology, but they overlap significantly in symptom.
Yeah. So perhaps some of this nasopharyngitis was also URIs. Maybe it's tough to tease those apart. Also, UTIs and zoster. There were 8 total episodes of zoster in this trial, and none were severe. Remember to vaccinate your patients before putting them on one of these, as per episode 86. That's adults anyway. There was one instance of a pulmonary embolus, and it was in the treatment group. Who knows if it was related or not? And there were 2 malignancies. Again, see episode 79 for a more in depth discussion of adverse effects in JAK inhibitors. Both of these malignancies were patients on treatment. They were both breast cancer in women in their 40s or 50s. The on site investigators thought one of these was related to the study drug and the other was not, but that's scary. Of course, we don't want to give people cancer, but take a listen to some of our previous episodes. The risk is really quite low. There were a few serious infectious events potentially related to the drug, including one patient who had both empyema, which is like pustule stuff in the lungs, and sepsis. Acne was not increased, though there was a bump in, quote, folliculitis. Patients had mild, generally transient, and clinically insignificant changes in lab values, including creatine kinase, white blood cell parameters, hemoglobin, and platelets, as well as total cholesterol, HDL, and LDL. I think the lab monitoring for these drugs is evolving. The investigators also performed audiology evaluations on all of their patients, apparently due to some unpublished data in, quote, chronic toxicology studies in dogs that showed reversible axonal neuropathy.
Mm.
Hear about this anywhere before, Michelle?
Hmm.
People on the Twitters aren't being like, don't take JAK inhibitors, they cause hearing loss.
I haven't seen that yet. I've seen a lot of people chit chatting about um, certain nitrous oxide releasing medications causing hearing loss, but
Well, it's the first I had ever heard of it, and these investigators did find 6 patients who had audiology abnormalities in the testing, but the patients didn't bring it up, so presumably patients didn't notice it. It was mild, I guess. And this was described as sensory neural hearing loss that was emphasized as not central. So it's not the brain, I guess, that's the nerves. Tough to say if that's
mm,
going to become an issue or not. My feeling is probably not. For a more in depth discussion of JAK inhibitors, again, including the black box warning, episode 79 is your go to episode for that. A few other tidbits: the pathophysiology of alopecia areata. Still hard to say what's going on exactly, but it may involve loss of immune privilege by the hair follicle. So remember, the hair follicle is supposed to be an immune privileged site, meaning normally immune cells are not allowed in. But
mhm.
if there's a breakdown in that barrier, then perhaps the immune cells can get in there, and since they're finding antigens they don't normally see, they can get excited. And some basic science research suggests that ritlecitinib may restore this immune privilege. I wonder if it gets restored temporarily, probably, or more permanently, which would be cool. So perhaps this drug could be discontinued, though it seems like, based on current data, most patients who discontinue whatever treatment they're on for alopecia areata tends to come back. Overall, I would say this ritlecitinib stuff is probably comparable to baricitinib, which was the first drug approved for alopecia areata, which we discussed in episode 87. But this is approved for age 12 plus. Baricitinib is currently approved for age 18 plus. I think it's approved at the 50 milligrams daily dose without this 200 milligrams daily loading dose for the first month, though that is what got the best results in the trial. And of course, whether or not the cost justifies the use of these medications is another discussion. Baricitinib costs $5,500 a month.
Oof.
This ritlecitinib stuff, the brand name is Litfulo, and it's about $4,000 a month, which is still a lot, but if we're anchored on 5,500, I guess 4,000 seems better. But honestly, they're both just way too expensive.
It is challenging accessing some of these medications, and it is wonderful that we have more indications that we can treat with targeted biologics. The finiteness of financial resources to treat patients is something that I think we need to be cognizant of. Um, for the patients that have severe disease, these treatments can, of course, be quite life changing. I think we can all think of a patient we've treated that's had alopecia totalis that's recovered and the change in their quality of life. But you're absolutely right. There are some ethical and global considerations that we have to put forward as well when we're choosing our therapies. But I'm excited about it.
Yeah, it's nice to have something else, especially something approved in the pediatric range. So that's the story with Ritlecitinib, and I feel after reading this trial, I will feel empowered to use it if I think it's appropriate. Well, friends, thanks for sticking around with us for this lengthier than normal episode. It was lengthy just because it was so chock full of awesome stuff. I'm sure you will all agree. And extra thanks to all of the members of Team Dermasphere who help us out greatly with every episode. Thanks specifically Morgan Dykman, Guy Kuseki, Eleonora Marcacci, Michael Birdsall, Aparna Nayak, Neha Deo, Haley Walsh, Angie Wong, and Laura Dela Cruz. You guys are awesome. A lot of you are applying to dermatology this year, so residency directors, please look kindly on their applications. Also, you can find us on social media. We are on Facebook, Twitter, and Instagram. And you can find us on our website, dermaspherepodcast.com, which has links to all of our articles that we have discussed, as well as our entire archive that you can listen to. It's also a good way to reach out to us. You can also find some of our content in video form now on the platform ViewMedi. That will be in the show notes. Remember, you can hang out with the University of Utah people, including myself, on our virtual echoes every month and also in September in Idaho. Again, the links will be in the notes. That is all for today, friends. We will see you in 2 weeks.